All right, so this is the April 2021 MEC Minute, and today we're going to talk about tubes and lines. So we're going to talk a little bit about tubes and lines that you're going to encounter either in the field or at the patient's home or maybe even at the ECF. And I'm doing this conversation today based on some questions I received recently from some of our providers. So just some general comments as we start. All the tubes, all the lines that we are going to discuss today require special expertise for placement. So these are things that typically we would not expect you to place in the field, but we expect you to have some understanding of the devices and how to problem solve if there are issues. If you don't know how to use the device, don't touch it. If there's some local complications with the device, we'll talk about how you can manage them. If you have a patient with one of these devices, you should be comfortable with how do you manage these devices emergently, or at least understand where some conditions or some devices may have time-critical interventions that you need to participate in. And then the last general comment about this subject is if a tube falls out or becomes dislodged, don't try to put it back in. So if you have a PICC line that's starting to fall out, we don't try to put them back in. Just secure it in place and move the patient. The only exception to this comment is if you have a tracheostomy tube that has fallen out or is malfunctioning, and that tracheostomy tube is necessary to support the patient's ventilatory machine, or the patient's on a ventilator, they're vent dependent, or they have to have the tracheostomy tube in place in order to maintain an adequate airway. If that happens, then you need to be comfortable with the concept of how do you manage that tracheostomy tube, how do you reestablish the tube, what do you put the tube back in, do you use a new tracheostomy tube if you have one available, or do you use an endotracheal tube to put in through the ostomy, and you can use that to maintain the airway until the patient arrives to the hospital where we can put the appropriately sized tube back in place. So those are just some general comments for you to consider as we get through this conversation. First thing I want to talk about is nasogastric tube and feeding tubes. I think nasogastric tubes are things that you have seen. They are actually within your scope of practice. You're more likely to see, however, a feeding tube in place or a feeding tube that's having problems for the patients that you serve as an outpatient arena. You'll see nasogastric tubes if you're doing an interfacility transfer or if you're transferring from a freestanding ED to a hospital-based ED. But for most of your other runs, you'll probably see feeding tubes that are small caliber, they're in the nose, and they're there for the patient to receive either hydration or nutrition or medications. So what do you do with these devices? When do we use them, and how do we expect you to manage them? So, we use these devices really for two different reasons. One is to decompress the gut. So the patient may have a bowel obstruction, they may have an operative procedure in the abdomen, and they may have poor gastric and intestinal function for a couple of days until the gut recovers. Or sometimes we'll use these devices to decompress the stomach or to empty the stomach because the patient has overdosed on a medication that we have to get out of the stomach. We used to put big bore and nasogastric tubes in all the time for overdoses. It was probably more punitive than therapeutic, however. But there are some medications such as iron that if the patient overdoses on, we need to do gastric decontamination to get that stuff out as quickly as possible. So we use nasogastric tube, the bigger tubes, to decompress the gut because of a bowel obstruction, or to decompress the gut because of GI surgery, or because the patient's overdosed. The feeding tubes, the smaller tubes, we use because the patient has swallowing difficulties. Maybe they have anorexia, they don't want to eat. Maybe they cannot swallow well because of a head and neck tumor, or because of an esophagus problem, or because they've had a stroke. So these devices function either to decompress the stomach or to administer food, medications, and hydrations. So what complications might you see? Well, the tubes can be displaced or kinked or blocked. They can cause discomfort. The nasogastric tube is a bigger bore tube. It's stiffer. It's more likely to cause discomfort. The feeding tubes are more likely to become kinked or blocked, particularly if they're not well managed and irrigated after use. So if you're giving a medication through a feeding tube, or if you're giving nutrition through the feeding tube and you don't irrigate the tube after the feed or after the medication, it can get blocked. Sometimes the tubes can get kinked, and often the tubes can be displaced. The patient can become agitated and pull it out. So what do you do if the problem solve? Well, for a nasogastric tube, if you're worried about its position, you can listen for an air bolus over the epigastric area. So you take a Toomey syringe, an irrigation syringe, and you push some air through it while somebody else is listening with their stethoscope over the epigastric area, and you should hear bubbling noise. If you have a feeding tube and you're trying to problem solve, really you have to first make sure it's in the right place. So if you're not sure that it's in the right place, you should do nothing. If you know the tube is in the right place, what we'll try to do at the hospital is we may try some Pepsi or Coke to irrigate the tube. These are fairly caustic substances, and if we can get some of that into the feeding tube, it will help break up whatever's causing the obstruction. If the tube is obviously out of place, discontinue the tube feeds, and if necessary, take it out if there's any concern about where it is. We can always put it back in. The other thing about tube feeds is if the patient is getting tube feeds via a nasogastric tube or a feeding tube, ask the family members of the patient or the staff members at the ECF to discontinue the tube feeds and irrigate it before you move the patient, simply because we don't continue tube feeds during transport. PEG tubes are a type of feeding tube, and the PEG tube is something that you can see in the epigastric area. So a PEG tube is put in typically via endoscopy. So they put the endoscope into the stomach. They can actually put a wire through the abdominal wall, and then they put the tube in, and the tube stays in place. The other thing you may see is a G tube, which is similar to a PEG tube. The G tube typically is inserted as a surgical procedure where the surgeon makes an incision from the outside of the abdomen and works inwards to get to the stomach. Feeding tubes, there's one in the middle there. It has several different ports. There's one port that is just to be used to inflate the balloon so that the balloon can hold it in place in the stomach and it doesn't back out. There's the bigger channel, which is the feeding port, which gets used for tube feeds. And then there might be a smaller channel, which is the medication port that can be used to administer medications. You'll also see on the feeding tubes a disc that is attached to the feeding tube, and that disc is usually is moved up against the abdominal wall, so there's not a lot of to and fro movement of the tube through the opening into the abdominal wall. So PEG tubes, we use these tubes, or G tubes, we use them for long-term nutritional support. These tubes bypass the mouth, so if you have a patient with a esophageal tumor that's blocking the esophagus, or if you have a patient with head and neck cancer, or a patient who requires long-term nutritional support, you'll see a PEG tube in place. Patients who have long-term nutritional support needs tolerate a PEG tube better than a long-term nasogastric tube. And because the PEG tube or G tube is a bigger caliber tube, they typically are lower risk to become obstructed. The complications you may see is the tube can become displaced, the tube can become blocked, whether it's with food or medications, or the balloon can break and the tube just falls out. So those are the complications you see. What you need to do, what are your actions? The biggest point I want to make here is if the tube falls out, that ostium or hole in the abdominal wall can seal off within hours. So while you may think about why did they call us to the nursing home because the G tube fell out, why didn't they call a private ambulance? Well, if the private ambulance is 2 hours away, that could result in a significant delay in replacement of the tube, and that ostium or hole may seal off. Once the hole seals off, the patient's going to have to go through another procedure, whether it's an open G tube placement by a surgeon or another endoscopic procedure by the gastroenterologist. Once that hole seals off, we can't put a tube back in through the hole. So that's why these patients, while not time critical, they really need to get to the hospital as quickly as possible so they can replace the tube. The other thing I would ask you to do is bring the tube along with you, because these tubes come in various sizes, anywhere from a 14 French to a 20 French. We like to put the same size tube back in, so it's nice to know what size tube the patient had. And the final thing is, if you notice any bleeding from the tube site, maybe the patient got a little agitated and pulled the tube out, you can control the bleeding with some local pressure. Typically it's not a big deal. Some local pressure and the bleeding is controlled. I threw these x-rays up there, talk about feeding tubes. These tubes are in through the nose. Which tube is in the right spot? So if you think about the feeding tubes, Our goal is to have the feeding tube below the diaphragm so it's in the stomach and we can safely administer medications. If the tube is above the diaphragm, then we cannot assume that the tube is in the correct position and we can safely administer medications or tube feeds or whatever. So if you look at these x-rays, the tubes that are placed for tube feeds have a weight at the end, and that weight is very radio opaque, meaning it's white on an x-ray. So if you look at the x-ray on the right, you see this marker, this bright red line, or I'm sorry, bright white line that's below the diaphragm. That is a feeding tube. It's in the right spot. So before we use a feeding tube, we will make sure that it's in the right spot by doing an x-ray. If you look at the x-ray on the left-hand side, you'll see that there's this feeding tube. It's above the diaphragm. It looks like it's in the right lower lobe of the lung. The area around the tip of the feeding tube is white, or is kind of hazy, which suggests to me that this patient probably has a feeding tube in the wrong place, and they may have gotten medications or some food through it, and now you've got either aspirated material within that area of the lung, or they've got a pneumonia. The interesting thing to me is it looks like the patient has an endotracheal tube in place. If you look up toward the top, you see two white lines that are parallel. That's either an endotracheal tube or a tracheostomy tube. If it's an endotracheal tube, you kind of wonder, or even if it's a tracheostomy tube, you kind of wonder how did that feeding tube get down there past the tube that may already be in place. Makes me wonder if the feeding tube went in, the patient developed complications, and then had to be intubated. So on the right-hand side, tube's in good position, we can safely use it. On the left-hand side, the tube's sitting in the lung. We cannot use it. It has to be taken out and reinserted. And typically when we reinsert, we start from scratch. Tracheostomy tubes and stomas. So we see patients routinely who have tracheostomy tubes in place. Typically, tracheostomy tubes are there because the patient has a need for long-term ventilatory support via a ventilator. Sometimes the patient just needs a tube there to maintain the opening, but they don't need the respirator. But sometimes we'll see patients, like on the right-hand side, that have had a tracheostomy and they have a stoma that's mature. So the hole is open, they can breathe through it, but we don't need to put a tube in there because the patient can move air on their own. Typically, we see these open stomas in patients who've had previous head and neck cancer. They've had a laryngectomy or some other surgical procedure, and the surgeon left the patient with a stoma. These patients typically can do just fine, but if the patient requires ventilatory support, then you're in a position where you have to insert a tube in through the stoma, whether it's an endotracheal tube or a tracheostomy tube, but you can use that stoma for an advanced airway. So these tubes are in place either because the patient had upper airway obstruction, such as a head and neck tumor, or they have long-term ventilatory support. The patient could have been, patient suffered cardiac arrest. They've been on the ventilator for 3 to 5 days. It looks like they're going to need longer-term support on the ventilator. So the pulmonologist or the surgeon will place a tracheostomy so that the patient has a better airway and you can take the endotracheal tube out. So these devices bypass the nose and throat for ventilation. The complications can be dire, so we have to be aware of what they are and how to manage them. The number one complication we typically see that is difficult to manage is airway obstruction. So there could be dried blood or dried secretions within the cannula, within the tube, within the tracheostomy tube, and the patient cannot move adequate volume of air past it. Sometimes we'll see bleeding. The bleeding could be immediately after the tracheostomy is performed. It could be a post-operative bleed. Typically, those are venous bleeds, so they're low pressure, they're non-pulsatile, and if you have a patient like that, just packing the area off with a 2x2 or a 4x4 is usually enough to control the bleeding. Sometimes the tracheostomy tube, the cuff has been overinflated and it causes tracheal breakdown, and that can cause some bleeding as well. Those are bad problems that are very difficult to manage, and really, other than transporting the patient, you don't have much you can do in the field. Infection is also a complication, either locally or as a consequence with pneumonia. You know, when you put a tracheostomy tube in, you are bypassing the protective mechanisms we have in our nose and throat to keep bacteria and other things from getting down in the lungs. So patients are more likely to get a pneumonia with a tracheostomy. So let's say you have the worst possible problem that we can think of, which is obstruction of the tracheostomy tube. What do you do? Well, these tracheostomy tubes, if you look at the picture shows the tube with the cuff. The tube in the middle is the inner cannula, which goes into the other tube. And then the obturator on the right is what you can use to put in through the bigger tube on the left, or put it into the cuff tube, so that it facilitates placement of the tracheostomy tube. So if you have a patient with a trach that's in place and there seems to be some obstruction, the easiest thing to do is to take out that inner cannula. It typically has clips on each side. You pinch the clips together and you can pull the tube out. You take the tube out, you can wash it out, clean it out, you can get rid of the obstruction, and if you slide it back in, the patient's going to breathe better. Bleeding, like I mentioned, if you have localized bleeding around the cuff, you can just pack it with some gauze. If you have actually bleeding coming up through the tracheostomy, suction the patient as best you can, move that patient, get them to the hospital. And if the device falls out, if the cuff becomes deflated, you can either replace the tube that the patient lost. It helps if you have the obturator to use it, or you can put in a new tracheostomy tube if you carry one. I don't expect you to have one on your MEC, but you might. Or you could use an endotracheal tube that's appropriately sized to put it in. If you use an endotracheal tube, just be careful. You really don't need to put much farther in than if you just put it in enough until the balloon disappears, because if you go too far down, you're going to get into the right main stem. So those are the quick issues that you need to be able to deal with in patients who have problems with their trach tube. Chest tubes, I just want to bring it up so you have some familiarity with it. You may see patients from home that have a chest tube in place because they have a chronic pleural effusion, and they may just have the tube in to help drain it chronically. Or you may see patients that you transport between a freestanding or from another hospital to a second facility. So why do we use chest tubes? Well, if you think about it, the lungs are normally elastic, meaning they want to recoil, they want to get smaller. The only reason the lungs stay inflated is because there's a negative pressure within the chest cavities. That negative pressure pulls or sucks the lungs up to keep them inflated. If you develop a air leak or you have a penetrating injury to the chest, that negative pressure is gone and the lung is going to collapse. If you develop fluid or blood or pleural effusion or empyema, which is a pus within the chest cavity, all of that can compress the lungs so it can't move. We put a chest tube in for those patients to get that stuff out so that there's more space in the chest cavity and the lung can inflate properly. So on the left-hand side, it's just a picture of how a chest tube sits. We want to put a chest tube in, we aim toward the apex of the lung. That way it functions the best. If you look at the chest x-ray in the middle, on the patient's left-hand side or the right-hand side of the chest x-ray, you can see that there is a device in there. It looks like a tube. It's got a bright line to it. That's a marker that's on all these tubes, so you can see the tube with an x-ray. And my red arrow kind of points to it as well. And if you follow that bright white line near the top of the tube, near the apex, you can actually see where the line has a disconnect. That's a opening. That's a port. That's one of the holes within the chest tube. On the right-hand side, it's a child. It looks like the child's intubated and has a nasogastric tube, but you also see on the child's right-hand side, or the left-hand side of the image, you see a pigtail catheter. And they use pigtail catheters a lot in children. We use them a reasonably amount in adults who have a spontaneous pneumothorax where we're not worried about blood or fluid. And the pigtail tube tends to be smaller caliber, and we can easily put them in. We use a stylet to straighten out the tube. Once the tube is into the chest cavity where we want it, we pull the stylet out. The tip of the tube wants to coil and it coils up and it stays in place. Those are good tubes, and you may see these tubes in patients who are at home, particularly if they just need to have it because of a chronic air leak or for drainage purposes. Typically, these tubes are hooked up to either a chest tube container. Basically, it that has suction, or they can be hooked up to a flutter valve or a Heimlich valve, so that anytime the patient coughs or Valsalva's, air is forced out, and the flutter valve lets air out but won't let air back in. So these chest tubes are always hooked up to something. So chest tubes, we use them because there's a pneumothorax, whether it's a simple or a tension, or we use chest tubes because there's fluid or pus or blood in the pleural cavity and we need to drain it out. These devices restore negative intrathoracic pressure, or they drain the pleural cavity. For us, the complications we have to worry about are the chest tube is displaced. So if you have a chest tube that may have 3 or 4 or 5 holes in it, and the tube is pulled out, and one of those holes is now out open to the air, you've lost the seal, the lung's going to collapse, and you're not going to be able to suction anything out of the chest cavity. So if the tube is displaced, we got a problem. If the tube is occluded, so sometimes if you have really thick, goopy pus within the chest cavity, or if you have ongoing bleeding from the chest, the tube can become occluded, and there can be issues because then you can't get suction. Or if there's just loss of a seal. So loss of a seal could be a persistent air leak from a injured lung, or the lung could be from a COPD who's got this big bolus, air sacs, and one of those air sacs leaks and continues to leak. You may just lose the seal and we can't get the lung re-expanded. What do you do as an EMS provider? Well, if you're transporting a patient with a chest tube, I would suggest you listen to the breath sounds on both sides before you transport to make sure they're equal. If there's any change in the patient's status, listen again. Are the breath sounds still equal? Think about, is the suction working? So know how to problem solve the suction unit that's in place in the chest tube setup that's in place, and I'm going to talk about it on the next slide. Do not try to replace the tube or push the tube back in. However, if you think the patient's developed an acute complication such as an acute tension pneumothorax, you listen to the chest, there are other symptoms to suggest acute tension, put a needle into the chest to decompress the chest, get to the patient to the receiving hospital. Here, these are this is kind of like the chest tube setups that you might see. It's really, no matter what we use, it's based on the concept of a 3-bottle system. If you look at the top left of this is the old 3-bottle system from the back in the 50s and 60s, and they have 3 bottles that are kind of daisy-chained in line. The bottom left is the more recent devices where they took a container and put 3 bottles into it, but they put water into the container to mimic what's used in the old 3-bottle system. And then on the right-hand side is the dry system, the Sahara Pleurovac system that most hospitals now use, where it's basically you dial up what you need and you don't have to put water in it. So if you think about how these systems work, the red arrows are all the same components. So in the old days, the first bottle we would see is hooked up directly to the wall suction. It has 2 other tubes. One is a long tube that's open to air but goes down into the bottle. And we put in that bottle water, and we like to think that we want 20 centimeters of suction. So we put 20 centimeters of water into the bottle, and we say 20 centimeters, I'm talking about height. And then the patient or the other tube goes to the second bottle. So the suction from the wall is going to suck at whatever rate it's set at, but this opening to the air via the fluid the bottle is going to limit the suction to 20 centimeters of water that goes to the next bottle. The middle bottle is just a bottle with 2 tubes. One of the tubes goes into water. That water is the air seal, or the water seal. So if you disconnect the patient from suction, that water seal will prevent air from going back into the patient. So that's the water seal. It's the safety valve. And then the third bottle on the right is the first bottle that comes from the patient. It basically has 1 tube that goes to the water seal and the other tube goes to the chest tube, and that just collects the gook that comes out of the chest. If you look at the so the second bottle is the pink arrow. That's the water seal. In the old days, we would put water into the plastic device that would serve as the water seal. And in the new device, it's just a dry setup. You don't have to worry about water. If you have the old system with water, the suction control chamber, the one that's set for 20 centimeters of water, that's always going to bubble. The second chamber, the water seal chamber for the water seal to keep air from going back to the patient, that will bubble as long as there's air coming out of the patient. And then the last bottle, the last chamber is the fluid drainage collection, and that's what we use to measure how much blood, pus, fluid, whatever comes out of the patient. So when we say we put a chest tube in and we drained out 350 cc's of blood, it's because chamber 3, the chamber under the green arrow, measures 350 cc's of blood. So that's kind of the setup we'll see. For you, if you're transporting a patient with a pleurovac in place, typically you can just transport the patient without having them hook up to suction, or you set it for 20 centimeters of water and you hook them up to your suction unit in the truck to keep the appropriate suction on the patient. And it's that negative suction, or the 20 centimeters of water of suction, that pulls air and fluid out of the chest cavity and into the container, into the pleurovac. Central lines, you'll see those out there. We see more and more PICC lines on patients who are at home. Typically, these patients need them either for hydration, but more commonly because they need 4 to 6 weeks of intravenous antibiotics, and we don't need them to be in the hospital during that period of time. So, we have those out there, and they are available for your use. You may also see central lines in patients. We use central lines at the hospital, but there are also long-term central lines like the old Broviac or Grashon catheters that may have been placed, and they are inserted for longer-term therapy. And the catheters were invented before we started using PICC lines. So I think most of the patients who would have had chronic central lines now have a PICC line instead. Both the PICC line and the central lines, the goal is to have the tip of the catheter in the superior vena cava. So if you look at the central line placement, the places where we put them is either in subclavian vessel, the subclavian vein, which is underneath the clavicle, and we tend to approach that by putting a needle in under the clavicle and going toward the vein, or the internal jugular, which is the neck. We are using the internal jugular for emergent access more and more, commonly because we can use an ultrasound to identify the vein and help guide placement of the needle, which reduces our complication rate. On this patient here, this chest x-ray, if you look at where the arrow is, that's the tip of the central line in the superior vena cava. If we had a patient with a PICC line, we would look for a similar position of the PICC line before we start infusing or using fluid. So once a line is placed, we always confirm position before we start using it. When do we use these lines? We typically use them for acute venous access in patients who have difficult peripheral access. Our patients are getting chubbier and chubbier. They're having more interventions accessing their veins, so it's getting harder and harder to find peripheral access. And we have more and more patients who've had a history of IV drug use where they've wasted their veins and we can't get into them. Or we use these lines when we have patients who need prolonged access for medications or IV fluids or hyperalimentation. These lines serve to provide central venous access. We can have complications with them that include catheter displacement. The catheters can become broken, kinked, or occluded. If the catheter is in the wrong place, the patient can develop a pneumothorax or have pleural effusions, or they can become infected. Sometimes patients will have a DVT, a deep vein thrombosis. So if the patient's got a PICC line in place, they may get a clot in either the axillary vein, which sits in the armpit, or the subclavian vein, which is the vein proximal from the axillary vein, and that sits in the chest cavity. And those patients, typically we have to do a scan, a duplex scan. If there's DVT, we take the catheter out, we start them on anticoagulants. Acutely, if these devices are put in the wrong place, or if something happens with the valves on these devices, patients can develop air embolism, where they develop acute dyspnea, chest pain, body aches. They can have acute altered LOC. They can become hypotensive, and they can develop cyanosis. For us, typically the most common complications we see is either an occluded device or a device that's infected or has DVT. What do you do to problem solve? If there's any questions, listen for breath sounds. If there's any concern about displacement of the device, stop the IV fluid. So if you go to a patient and they had a PICC line in and it's half out and they're getting an infusion through it, stop the infusion until we can verify the line is acceptable for use. If the device is occluded, we need to transport the patient because the device will have to be replaced, or we may have to open it up with TPA. Just a helpful hint, these devices tend to have clamps on them, particularly the central lines up in the chest. If the line isn't working, make sure the clamp is open before you start worrying about the line being occluded. And if you're worried about an air embolism, the treatment is Trendelenburg with the patient on their left side and the head down. To access these lines, you can access these lines. You should use sterile technique. They all have valves on the end. Make sure the clamp is open, clean off the valve, put a empty syringe on the valve and aspirate. You want to get blood out before you put anything in. If you cannot aspirate, you're done. Don't use the line. Because the first thing we'll do when we see the patient is verify the line is correctly placed. If the line is in good position and we cannot aspirate, we will then probably inject a couple milligrams of TPA into the line. It sometimes can be a bit difficult, but we do it under pressure. And we let it sit for an hour, and it typically will dissolve any clots that may be obstructing the line. SubQ ports, just to mention, they are out there. On the left is the device before it's placed. In the middle picture, it's how they place the device. Typically, it's in the upper chest. And if you look at the x-ray on the right, that big white thing at the top, that's the subcutaneous port, and you can see the catheter going up into the chest cavity. These devices are out there. We use them for central venous access for patients who need intermittent treatment, such as chemotherapy. They are much easier on the patient than having multiple peripheral sticks, and they're easier to maintain on long term than a PICC line. And these devices can become infected, they can become occluded, and they can fracture. For us, I'm saying this mostly so that you're aware of them. If these devices are present, we currently do not have in our protocol that you can access them. It requires special training, special equipment. I know some of my agencies in the past have accessed these devices, but we did have the equipment and the training. It's just when we have 17 agencies and 500 providers, it's difficult to keep everybody up to speed on how to access these devices. So if you see in your community that there's a big need to have access to these devices, talk to your EMS coordinator and see if they can make a good argument that we should look at putting these back into the protocol. But I do want you to be aware of them. And the last comment is we should never access these devices if there's any evidence of malfunction or if there's overlying infection. The last thing I want to talk about are dialysis catheters. You'll see these, more and more patients are on hemodialysis, and these catheters are present. These devices typically are 2-channeled, but some of them may be 3-channel. And each of the ports are color-coded, and they all have valves on them or clamps to open and close. So really, if you look at the colors, the blue valve is the venous valve. It's the valve that's used to pull blood out of the patient. I'm sorry, it's the valve that's used to have blood go back to the patient. And the red valve is the arterial valve, with the idea that arteries are red, they take blood away from the heart. Veins are blue, they bring blood back to the heart. So when the patient's hooked up to the dialysis machine, the red valve is used to take blood to the machine. The blue valve is used to return blood back into the patient. Most of these catheters are in the upper chest or the neck. Occasionally you'll see these devices in the groin. We try to avoid the groin simply because it tends to be a little more uncomfortable, but more importantly, it's easier for the devices to get infected in the groin, so they try to avoid the groin. Some of these devices may have a 3rd channel that can be used for routine vascular access. Honestly, I haven't seen one in our area in a long time. So I know they're still out there, I just haven't seen them commonly used. There. What do you do? If there's bleeding, local pressure. Otherwise, leave the device alone. If it's partially fallen out, leave it alone. So really for you, it's a little bit of bleeding, local pressure, leave it alone. We often discuss whether or not EMS providers should access these devices in a critically ill patient. My response is do everything you can to avoid accessing these devices. These devices are special. They have to be maintained in a pristine state. The nephrologists, the kidney doctors, and the dialysis centers get really fussy about who touches these devices. If you touch these devices, you should have a gown and gloves on, a face mask. You should clean the area, follow appropriate sterile technique. Really, we need to stay away from these devices. If you have a patient where you can't get vascular access via an IV or an intraosseous device, and there's a catheter present and you have to access it or the patient's going to die, then okay, access the device. But find every other option or try every other option, consider every other option before you go to accessing the dialysis catheter. If you have to, go to an IO before you access the catheter. So I think that's all I have. I've covered all the topics for today. If you have any questions, please pass them on to your coordinator, and they can pass them on to me. Next month, I kind of want to follow through on this discussion and go from tubes and lines to medications not in protocol, but medications that you may encounter in the field. And those could be medications from a surgery center, medications from a freestanding ED, or even from a physician's office. So next month, we'll talk about some of those medications. So that's all I have.